Good afternoon, everyone, and welcome to today's webinar entitled HIV, Let's Have Hope. We're glad that all of you could join us as we have an exciting presentation in store for you today. My name is Deanna Fenton, and I'm the Program Coordinator here for the Alliance. Now, we do have just a few logistical items to review before we begin today's presentation. For those of you who have never joined us on this webinar platform before, the chat feature is located in the bottom left-hand corner of your screen. Now, we are recording this webinar, so we will not be opening phone lines during today's presentation. That means that all questions must be submitted electronically using the chat feature. If you have any questions that come up during the webinar, please feel free to submit them at any time. Once the presentation is complete, we'll have some time for our presenters to address as many of your questions as time allows. Now, registration is currently open for our next webinar entitled Brain Death Declaration, Moving Toward Better Quality and Uniformity. That's coming your way on November 7th at 2 p.m. Eastern. Registration is also open for our upcoming webinar entitled Shades of Grief, Mourning and Grieving Experiences Between Minority Populations. That's coming your way on November 13th at 2 p.m. Eastern. You can register for all of these webinars and more on our website at organdonationalliance.org. Now, for those of you who may be interested in obtaining continuing education credits, we are offering one Set C credit and one contact nursing hour courtesy of Iowa Donor Network. Everyone listening to today's webinar is entitled to claim these credits. If you're listening in a group, as many of you are, please make sure to get the evaluation email from your group lead. It's a very brief online evaluation which will allow you to receive your credit. As a reminder, for nursing, you have 14 days to claim your credits, and for Set C, you have 30 calendar days. At this point, I'd like to introduce our moderator, Nicola Ehrenberg, Nurse Supervisor at UCSF Medical Center. Nicola, we're so glad that you can join us today, and at this point, I'll turn it over to you to introduce our speakers.
Perfect. Thank you for the introduction, and thank you to everyone for joining the webinar today. I'm really delighted and really excited to introduce our three speakers for the webinar today. First of all, it's our own UCSF Dr. Stock. He's a professor of surgery and a multi-organ transplant surgeon for the UCSF system. He performs kidney and pancreas and liver transplants. He also serves as a surgical director of the kidney and pancreas transplant program at UCSF, as well as the pediatric transplant program. His translational research explores beta cell replacement for the treatment of diabetes type 1 and is currently co-director of the UCSF Pancreatic Islet Transplant Program and was the co-PI on the California Institute of Regenerative Medicine Stem Cell Initiative to bring stem cell-derived beta cells to a clinical trial. He is also co-investigator for the NIH-sponsored clinical trials in islet transplantation, as well as the site PI on the NIH-sponsored clinical trials in organ transplantation. It's studying the introduction of transplantation tolerance to block alloimmunity and recurrent autoimmunity following solid organ pancreas and pancreatic islet transplantation. He's the principal investigator on the NIH U01 multi-center trial studying the immune response following liver and kidney transplants in people with HIV. Dr. Stock was the president of the American Society of Transplant Surgeons from July 2014 to May 2015. Additionally, we have Phil Brown. He's the research manager from Donor Network West, where he focuses on the implementation of new research projects, recovery, and engaging staff to better understand anatomy, perform research recoveries, and bolster understanding of the mechanics of organ recovery. Contributing to the HOPE Act allows the ability to combine professional trade and educate a larger population. Phil's goal is to help emphasize the ability to break away from the stigma and promote heroes while further paraying the gift of life equity to those who need it. And our last speaker is Brianna Doby. Brianna works for the NIH-funded HOPE in Action study at the Johns Hopkins School of Medicine. Brianna is the donation community consultant on this team study and supports organ procurement organizations in all aspects of HIV-positive transplantation and donation, from donor registration to family approach to public education. Previously, Brianna worked for nonprofits around the country with her company, Positive Rhetoric, as a stock issues consultant and a speechwriter. Thank you very much for the speakers in joining us today, and now I'll pass it over to Dr. Stock.
Okay, thank you, Nikki, and good morning, good afternoon, actually, for most of you. What I am going to address is really a change in the landscape of who we do transplants in. This first slide here shows what it was like in July of 1985 when I started work on my PhD when I was a surgery resident. And that was the cover of Life magazine that really shows what the fate of people who were infected with the HIV virus had. And that has completely transitioned to this other world that was on the front page of the New York Times, and it highlighted the work that was being done by the group at Hopkins and Dory Sagev, and one of his medical students named Brian Boyarsky. And
sorry about this, everyone. We're just obviously having some technical difficulties while we get Dr. Stock back on.
All right. And so my half of the presentation focuses more on the OPO perspective of the HOPE Act and HOPE in Action study. As of August 31st, there were 25 transplant centers participating in the HOPE Act. As you can see in this map, UCSF and Donor Network West were the only transplant center and OPO participating in our region, which is Region 5. I do have to mention and commend One Legacy, UCLA, and USC, who are also in the process of joining Johns Hopkins in participation in the HOPE Act and HOPE in Action research study. According to the CDC, the highest prevalence of HIV per 100,000 people is actually in the DC, Baltimore area, followed by the Southeast, Georgia, Louisiana, and Florida. Next on the list is Nevada, with Texas and California following shortly thereafter. From the beginning of 2016 to about this time last year, there were 31 transplants performed under the HOPE Act. So where did these occur? The majority of transplants occurred in Region 9, which includes New York and Western Vermont. That was followed by Region 2, which includes Delaware, the District of Columbia, Maryland, New Jersey, Pennsylvania, and West Virginia. Looking at our region, Sorry about that. Looking at our region, Region 5, we can see that we are indeed making a contribution, but should be able to do more in terms of transplantation and research based on our HIV population. So moving on to the current national data. So as this graph shows, the number of HIV-positive transplants has doubled in the last year. This is pretty incredible. We went from 17 to 37. That bar next to the donor list is the actual number of transplants. As of August 31st of this year, there have been 65 transplants from 37 donors, with 68 blood samples sent off to Johns Hopkins for research. And of these 37 transplants, there were, of all the samples sent to Johns Hopkins, there were 37 HIV transplants with 28 false positives. Again, focusing on our region, Region 5, and here at Donor Network West, we've picked up the pace in the last year, but still have work to do. Donor Network West itself has produced 3 donors in which we were able to place 1 liver, 5 kidneys, and have sent 7 blood samples to Johns Hopkins for research. If you include organs imported for transplant, UCSF has been able to transplant 1 additional liver and 2 more kidneys through the HOPE Act. This raises our regional total to 9 of the 65 HIV-positive organs transplanted from the HOPE Act as of August 31st. We have since had 1 additional donor that has produced 2 additional kidneys for transplant. So our totals are now 7 donors, including imports, with 11 transplants and 8 research samples sent. So in regard to our region, why do we not have higher numbers of potential donors? Well, data shows that we actually do, but there are a few complications. The largest being that we didn't realize these patients would be so sick and are not being hospitalized for the usual mechanisms for brain death. We have found that many more are referred under the DCD criteria. Looking through our data, we have found out that 45 donors rule out medically. 28 organs were declined for quality by transplant centers. We've had 5 families that had no plans to withdraw that care for a DCD possibility, and 3 have declined transplant or research completely. We also thought there would be more awareness of the HOPE Act and study amongst the HIV-positive population. What we found was that many families either don't convey their awareness of HIV status or are completely unaware that their loved one is HIV positive. A large portion of this population is also estranged from their families, which makes finding next of kin very difficult, and thus the donation process even more. As mentioned before, many are referred from DCD queues, which makes allocation of resources very difficult. And last but not least, prior to this year, we at Donor Network West did not allocate resources for research only, which has since changed. As with any project, we expected that we would have some roadblocks, the biggest being the negative stigma of HIV and AIDS. Our hope is to help erase this stigma through education and, of course, successfully transplanting this population, as an HIV-positive patient would have previously been ruled out as a donor completely. So what happens if your HIV assay is positive, but NAT testing is negative? Is that still a HOPE candidate? We consider that as absolutely. Again, these donors would have been previously ruled out, but through the HOPE Act, we're able to move forth with transplant and donation. So lastly, what if we do if the physicians do not want any part in disclosing HIV status? We will still pursue donors for transplant and for research without knowledge of HIV status. In this situation, our Chief Medical Officer, Dr. Nadlinger, is involved to determine need to disclose HIV status on a case-by-case basis, mainly focused on potential risk of spreading infection. We have taken a stance to notify the Public Health Department and allow them to notify families unless there's an extenuating circumstance, especially with the research arm of the Hope in Action project. From there, if transplant is not possible, we are able to provide the research option of collecting blood to help future patients on the list by expanding the ability to understand and transplant HIV-positive organs. This allows us to assess the need for immediate release and fully disclose the implications with the family. Some families will fully welcome media attention, while others will have additional considerations. So, what are we doing to improve the transplantation of HIV-positive organs? We have recently resurrected our organizational models to create clinical operation managers who oversee each case and have a much better understanding of the suitability of transplant for these cases in particular. We remain in regular communication with the resources from Johns Hopkins, especially Brianna, and have designated leaders from the clinical, research, and family services departments at Donor Network West to be experts on the needs for each step. And last but not least, to reach out to our trusted physicians such as Dr. Stock to help determine suitability for these organs. As mentioned earlier, we now allocate resources for research only to obtain consent and to collect blood samples for research. Of course, Organizationally, we cast a wide web of education to encompass all topics that may arise for each department. In addition to those steps, we're also currently creating job aids and reference material to streamline all aspects regarding the HOPE Act to make very clear and concise direction to avoid any confusion and allocate resources appropriately. In the event a hospital provider agrees to notify the family of an HIV-positive result, but is unsure of what to say when disclosing positive results, we also provide language to share with the family. In this slide, as it reads, as part of our collaboration to ensure patients and their families receive all options at the end of life, when certain markers are met, a donor assessment is done, including testing for certain communicable diseases. At this point, it is our responsibility to disclose the following positive results. So allow me
Oh, he's gone.
Can you all hear me now?
Now we can.
We can hear you.
Okay. So allow me to share a case study with you. Allow me to share a case study with you. So, a pair of sisters, one 20 years old and the other 22, were driving home from school when their car was struck by a semi-truck. The 20-year-old sister passed away on the scene as the other was transported to a local hospital in Donor Network West service area. The family supported donation for both daughters, but the elder daughter sustained many non-survivable injuries, including a grade 4 laceration to her right kidney. The first heartbreak occurred upon learning of the younger sister's death on scene. The coroner restricted all tissue recovery pre-autopsy, which unfortunately led to the younger sister timing out for all tissue donations once the autopsy was completed. There was, however, a shimmer of hope as we received a concurrent referral from the local hospital for the older sister. At this point, we as an OPO had to do all we could to respect this family's wishes. The local coroner's office was aware of the concurrent referral for a potential organ donor and acknowledged the missed opportunity for the sister to donate as well. They gave full relief and offered whatever services needed to accommodate the family and DN West's efforts. Our family services team worked with the coroner to allow members of our staff access to the younger sister's body to make hand and footprints to accompany the older sister throughout her stint in the ICU, and in the OR, they could remain in some way together. As per normal protocol, ID testing was drawn, sent out, but returned with a positive HIV assay, but negative HIV NAT test. This young lady had no increased risk factors, so we considered this a false positive. The testing was repeated at another lab with the same results, HIV positive, assay positive, NAT negative. A Western blot was also sent for confirmation, but returned negative as well. So, what do we do from here? Before the HOPE Act, this donor would have been ruled out, shutting down the case and preventing a beautiful family a glimmer of light in their absolute darkest of times. Even though this was considered a false positive, the HOPE Act allowed the possibility to provide the gift of life. In the case of the older sister, the liver and left kidney were unfortunately ruled out for transplant, but the right kidney was recovered and transplanted at UCSF by the one and only Dr. Stock. In addition to that, we're also able to send blood to Johns Hopkins for research. So what did we learn from this process? In the case first of all, the team at Johns Hopkins are a tremendous resource and are more than willing to assist and provide their expertise in any facet from research to transplant to logistics. When faced with a situation of initial notification of positive ID results, it's best to keep the conversations to the immediate family members and allow them to pass down the information as they see fit. Here, early activation of resources is key. Our family resource coordinators were able to hop into action quickly to create positive light on this grim situation. And last but not least, as an OPO as a whole, we educate staff toward what the HOPE Act entails and emphasize the fact that we are all here to heal lives through organ and tissue donation. So Dr. Stock and I have given this presentation to urge participation in both the HOPE Act and HOPE in Action study to create a longer list of potential recipients. As you can see, this donor's liver match was very short. We only had 2 recipients, which were declined for quality or recipient refusal. There were, however, more potential kidney recipients. The left kidney, as I said, was ruled out for trauma, while UCSF accepted and transplanted the right kidney. So I'd like to first thank Brianna Dovey from Johns Hopkins for being here and urge anyone, before ruling out an HIV-positive donor, please call the team at Hopkins, and they'll be able to assist in any sort of, again, logistical, operational needs that may arise.
Perfect. Thank you so much, Phil, for your really interesting talk. We actually have Dr. Stock back on the line, so let's pass it back over to him so we can start at the beginning again. Thank you, Phil, and over to you, Dr.
Really, my point and the way I wanted to start was just that, you know, when I first started my residency in 1982, I'm sort of old. We never ever thought that we would be doing transplants in people with HIV. This was the cover of Life magazine. Basically, HIV was a death sentence with rapid progression to AIDS, and that evolved to this this second article that was published in the New York Times, and that was an article about this push by the group at Hopkins, led by Dori Segeb and a medical student named Brian Boyarsky, who wanted to utilize HIV-positive donors and HIV-positive recipients. And that was based on work that had already been done in Cape Town, South Africa, by a woman named Dr. Elmi Muller, who's now the chief of surgery at Groote Schuur Hospital. And in Cape Town, if a patient had HIV, they weren't eligible for dialysis. So it was quite problematic. It was a death sentence. And at the same time, the frequency of HIV positivity in their donor population was huge, especially in the young population. Over 20% are HIV positive. So rather than throw out those organs, she used them in HIV positive recipients, ended up having very good results. And that, combined with the fact that we saw this increasing need in the U.S. population, prompted the Hopkins group to move forward with the HOPE Act, and you already heard of one very important case. Now, just to tell you about the need, there are well over 1 million people infected with HIV, and we still, unfortunately, are seeing 40,000 new cases a year. The life expectancy is high, but the same risk factors for HIV, including hepatitis, for HIV, are shared by hepatitis C and hepatitis B. So the frequency of hepatitis C co-infection is high, over 30%. That's probably going to be changing, but that's what it's been. The prevalence of hepatitis B is 10%, and progression to cirrhosis in this population is very rapid, to the point that liver disease has now become the major cause of death in people infected with HIV after infection. So the other thing that is important to know, that HIV nephropathy is a problem in people of African descent. And in the United States, it's become the third most common cause of renal failure in young African Americans. You can only imagine what the problem was in Africa that prompted Dr. Muller to move forward. At the same time, there was a big protest here at the University of California, San Francisco. We had already started to do transplants on people with HIV, but we felt that it should be done according to an experimental protocol. And unfortunately, experimental protocol is a buzzword for insurance companies to deny payment. And so the HIV community here in San Francisco, ACT UP specifically, was very angry at us for saying it should be done according to a protocol. And even though we were doing transplants in people with HIV, there was a big protest in front of our hospital. And they threw coffins down and they said we were in charge of genocide, and it was really very disconcerting. But the punchline is it was a very effective group in getting the ear of local politicians and state politicians, and they got us funding to transplant. I think they got us $3 million, which paid the cost of liver transplants in over 10 patients, and that provided us the seed money, the pilot population, to move forward with a very large national trial. And that culminated, you can look where all the stars are there. That's the hospitals that saw this need of transplanting people with HIV and participated in this original trial. And I'm going to fly through these next set of slides, and if you have specific questions, we can get to them later. Because I really want to have some time to come back and talk to and have Brianna have the opportunity to talk about the HOPE Act, because we now have this significant list of patients with HIV that need transplants. And just I don't know how many of you on this call are in transplant, but if you have kidney failure and you're waiting for a cadaveric kidney in San Francisco, you're waiting about 8 to 10 years. And it's the same on the coast and on many of the places where you see these red stars. And if you are willing to take an HIV-infected donor, your waiting time is probably less than 6 months. And as you know, we have been using hepatitis C positive donors and hepatitis C positive recipients. And at my own center, with a list of about 5,000 patients with hepatitis C can get transplanted within 3 months if they're willing to accept a hepatitis C organ. And we hope the same will be true for the livers. So what did we learn? Let me just cut to the chase. Here's the results of kidney transplants in HIV-infected patients. And if you look at that top red line there, that's the scientific registry, the national database of all transplant patients. The dotted blue line at the bottom is patients over the age of 65. Those are patients who are highly selected for transplant, but still considered candidates. And that's sort of the same. That's maybe a better comparator for the HIV-positive population. And then look at where the black line ends up. Those are HIV-infected patients, and pretty much patient and graft survival is very comparable to the population. So HIV really should not be a contraindication. What was surprising is this very unexpected finding. The red line there represents the incidence of rejection. And you can see that curve climbs steeply in the first half year and ends up at 2 to 3 years around 40%. That is well over 2 to 3-fold the rate that we see in HIV-negative patients. And we know that each rejection episode, even though we can reverse them, takes a little bit of life out of those kidneys. And that blue line represents the GFR or the kidney function in patients who had rejection. And you can see it starts to get worse. Now, the data that we published in the New England Journal of Medicine was 3-year data, and we hadn't yet seen the patients lose function. But we're now 10, 15 years out, and we're starting to see these patients for retransplant. Yet another really important reason to use every donor, including the HIV-positive donors, for those patients. I don't want to get into a great deal of depth regarding why this acute rejection episode happens. Many people thought it was because we were not using the right immunosuppressive drugs. But really, it was more that there were difficulties in achieving adequate levels of immunosuppression. The way we traditionally monitor the allografts, we look at trough levels of the drugs tacrolimus and cyclosporin. And even though the target levels looked right, there is terrible drug-drug interactions that happen in patients on the protease inhibitors for HIV. And even though their trough levels looked right, their drug exposure was completely whacked out. Now, the other thing that I would say is we are studying the immune system in these patients, and it's clear that in addition to problems with drug exposure, patients with HIV have a dysregulated immune system. And I want to point out it's not the absence of an immune system, it's the presence of a very dysregulated system. What you need to take home from this webinar is if you are considering liver or kidney transplants in patients with HIV, you need to get them off of the protease inhibitors that are used in the HIV regimens. Those protease inhibitors inhibit what's called the cytochrome P450 system, the system that metabolizes the HIV drugs, the immunosuppressive drugs. So as a result of that, the patients who are on protease inhibitors only need very small amounts of the drug to get them adequate drug levels. But by giving them those low levels of drugs, their overall exposure is inadequate. And these two teams, one in France and one in Spain, were way ahead of us, and they realized that if they could get patients off of the protease inhibitors and put them on these newer regimens that are based on integrase inhibitors, it's just a different class of anti-HIV drugs, then all of a sudden the rejection rates plummeted and the drug exposure was easy. So again, if you don't take anything else out of this talk today, keep in mind, get your patients off of the protease inhibitors, talk to your HIV providers, make sure that it's safe to do it, and if you can, get them on an integrase-based regimen that avoids these drug-drug interactions. Now, I don't want to spend too much time talking about the science of rejection in this patient population, but I just want to say that we have another trial going on right now that is looking at a drug called Maraviric, which is an anti-HIV agent that blocks what's called the CCR5 receptor. And the CCR5 receptor is the same receptor on the T cells, the CD4 T cells, that are the entry port for the HIV virus. It turns out that there is this study that was quite old, that was published in 2000 in The Lancet, which looks at patients that are homozygous for this for the CCR5 delta 32 mutation. It's a defect in the delta 32 mutation, or it's a defect in the CCR5 receptor. And what was so fascinating, remember these are HIV negative patients. Look at the results in somewhere around 20 or so patients that were homozygous for the CCR5, for this mutation in the CCR5 receptor. They had nearly perfect graft function out 20 years compared to controls. And keep in mind, this data came out in the year 2000, so these were patients that were transplanted in the 80s. So this is this is incredible data showing that if you could, block the chemokine receptor, the CCR5 receptor for HIV, maybe we might decrease the incidence of rejection. And there is this drug called Maraviric, which blocks CCR5. And so we are proceeding with a trial to block CCR5 using the drug Maraviric in patients with HIV. It's a blinded randomized study, and we're going to see if we can inhibit or protect these patients from the effects of rejection, because the chemokine blockers would block the trafficking of the T cells to the end organ. And we're hopeful that maybe this drug will be helpful in preventing chronic rejection, or the terrible fibrosis that we see in kidney transplants long-term that have been subjected to rejection. And interestingly, this drug is also being looked at in the management of hepatitis C and liver fibrosis, because it may be a very effective agent in preventing fibrosis in the liver. So stay tuned for more information on that. I don't want to talk about those two because we really are limited with time now. But I also want to talk about a drug called sirolimus, because sirolimus is a drug that that is used in many of the immunosuppressive regimens. Many of you may have heard of it. It turns out that sirolimus downregulates the CCR5 receptor. And in our initial UO1 trial, we saw that people who were on sirolimus, these are HIV positive patients that were on sirolimus, we looked at the reservoir of HIV in the circulating lymphocytes, in the CD4 positive cells. And we found this fascinating observation that people on the TOR inhibitor being sirolimus, they had a reduction in the reservoir, or really the persistence of HIV DNA in the circulating lymphocytes. So now we had an HIV drug, Maraviric, that may be helpful in rejection, and at the same time we have an anti-rejection drug, sirolimus, that may be effective in the management of in reducing the HIV virus and controlling the virus. So really, it's very serendipitous findings. We've come full circle. The immunosuppressive drugs that we thought were so dangerous may actually have anti-HIV qualities, and the anti-HIV drugs that we thought might be effective to treat HIV may have really interesting immunosuppressive qualities and are being studied to this day. And I think there may be a role in HIV-negative patients. Now, I just want to spend a brief amount of time talking about the liver, because when you look at all the ways the HIV virus and the treatment for HIV impacts the liver, it's amazing that we can get away with transplanting it. Not only do you have the problems with the viruses that affect the liver, substance abuse that affects the liver, opportunistic infections that are seen in HIV patients like CMV that affect the liver. You have all the antiretroviral drugs that have some toxicity to the liver. Not only that, some of the antiretroviral drugs cause diabetes and dyslipidemia, leading to fatty liver, which is yet one other cause of liver failure. So, like I said at the beginning, it's amazing that we get away with it, but we do. And the reason we know we get away with it is for patients that were co-infected with hepatitis B, our results were impressive. Basically, if you look out 5 years, the patient and graft survival were more or less the same. It wasn't statistically significant. But with hepatitis B, we knew how to control the co-infection with hepatitis B. And interestingly, HIV simply wasn't an issue. It was the co-infection that was problematic. And for those of you in the world of hepatitis C, you know that in liver transplant, until a few years ago, just a couple of years ago, the treatment for hepatitis C was limited to interferon-based therapies, and it only worked about 20% of the time in people with genotype 1, which is the prevalent genotype in the United States. And look at our results. Because we couldn't control the hepatitis C, our 3-year patient survival was 60%, and certainly less than 50% at 5 years. And that was problematic because every center in the United States stopped transplanting people with hepatitis C. And we barely were hanging in there because the government regulates our programs, and if we have poor results, we get into trouble. And that trouble or our results are made public. And so for many different reasons, all the programs in the country stopped doing transplants in people with co-infection. And you can see here's the graft survival at 3 years, which is 53% in the co-infected group. The other interesting thing to know about our liver recipients that it was that 50% of the rejection episodes occurred within 21 days of the liver transplant. So just like with the kidney, we saw 2-fold higher incidence of rejection, and it happened early on. So once again, you've got to make sure that if you're considering a transplant in a liver or a kidney or any organ that is being transplanted in a patient with HIV, get them on a regimen that avoids the protease inhibitors, and your rejection rates will get better. We know that in the liver, treated rejection was a major predictor of graft loss and severe HCV recurrence. That, of course, is all changing in the new era because we have these wonderful, miraculous direct-acting agents that can be used to treat hepatitis C. This slide I just put in there to show that the results that we were having, the problems that we were having with patients with hepatitis C, were also seen across the ocean. And it was all related to problems with recurrence of hepatitis C. You all know about these amazing drugs, sivosclavir, ledipasvir, and we found that all of a sudden we could cure our patients even if they were co-infected with hepatitis B and HIV. We have another NIH protocol that's studying this right now. So now centers are now reconsidering transplanting patients with hepatitis C. I have to tell you the uptick is slow, but if we have more organs readily available, I think that the results for patients with hepatitis C will be right back to the levels of the results seen with hepatitis B. And so now the problem is going to become, can we get people transplants? I mean, every year, HIV negative patients, every day, patients are dying waiting for livers. We don't have enough. Not only that, in the Bay Area, in New York, and in many places in the country, livers are allocated according to something called the MELD score. And you have to get really sick, a really high MELD score in order to get a liver. And for folks with HIV, they don't tolerate that. So we need to get the patients transplanted much quicker, and hence the HOPE Act. President Obama signed the HOPE Act in actually in 2014, and that's me that he's looking at. I won't tell you what I said to make him look at me like that, but the guy next to me is Brian Boyarsky, who is the medical student at Johns Hopkins, who along with Dori Segev changed the bill. So it's pretty exciting time, and that was supposed to lead into Phil's talk on the HOPE Act. But I'm going to stop my talk there because I really want to. I know Brianna from Hopkins is on the call, and I don't know if you want to say anything, Brianna, and I don't know, Nikki, if you want to how you want to do this, but I'm sure people have some questions for you, including me, and also a questions for Phil, and I have some for Phil too. So thank you very much. I'm really sorry for that little glitch in technology, but that's it for me.
Brianna, are there any additional comments you would like to? Sorry, go ahead.
Oh,
Sure. Just two quick notes. One thing that I wanted to point out, thank you so much, Dr. Stock. That was so enlightening. About 25% of our current HOPE candidate list nationally is co-infected. That number does change, obviously. But we have anywhere from 300 to 400 candidates listed at this time. And there are right now in progress 4 centers that between them, when they're fully online, will add another 100 to 200 candidates according to the numbers that we have. So it's a small but mighty list right now, and we're adding West Coast centers as well as Midwestern centers, and Miami Transplant is coming on board too.
Great. Thank you. Sorry, am I still on, or am I been muted?
No, we can hear you.
Okay, so Brianna, I know there's going to be some other questions, and I want to let people ask them. But before we go on, I was talking to Phil the other day about this requirement to tell families to disclose the HIV status of a donor and as part of the consent process to donation. And I don't get that. Personally, I don't see why it's necessary, and I know I see you made a comment here. Can you clarify that whole deal? Because I think we lose a lot of donors that way.
Sure. Thank you. That's a very good question. So there are 58 federally mandated OPOs across the country, and there's 50 states, all of which have their own unique HIV disclosure laws. And so what we're finding is that different OPOs do handle this process differently. Some of that has to do with duty to warn laws, right? So if the legal next of kin is someone who would fall under a duty to warn category, a partner, a spouse, that might change the way your donor hospital as well as your OPO might handle that. But every OPO is different in how they're handling it. Just to be very clear, I want to make sure everyone hears me, whether you're at a hospital, a center, or an OPO. Our study and participation in research under the HOPE Act does not require disclosure of HIV status. And I think that, individually, OPOs are making their own decisions about how they treat disclosure, but our study, Hopkins, would never be in touch with your potential donor family. Whatever required reporting you have to do, right, if you need to contact the Department of Health, however the hospital also would handle that, those are the same types of things that you do for a hepatitis C positive donor or any time when you have to talk about infectious disease. But for us, we don't actually advise disclosure, mostly because we want you to stay on the right side of those HIV disclosure laws within your own state. And also, this is a very this is incredibly sensitive and important for a lot of folks. And if they haven't shared their status with their legal next of kin, that may be for a very good reason that they held personally. So we wanted to make sure that they could still participate as an organ donor or a research donor as long as you have research authorization without having to know of their loved one's HIV status.
Yeah, I mean, to me, to have to disclose that kind of status at that point where people are suffering, and to have to tell them this news, especially because half of them are false positives anyway, it seems to me to be ridiculous. So I'm glad to get that clarification, and I think we need to work on things within our. I mean, Phil, what are the requirements here at Donor Network West?
The requirements here in California is that as far as I know, we have to notify family of next of kin. But again, with these patients, they're coming in as DCDQs, so these patients are living patients, where we as an OPO have absolutely no business speaking to a family at that point. So that's where the physician notification came in. We've discussed that with our higher level executives, and again, they've come back to report all the new confirmed diagnoses to the public health. and not the family or next of kin, except under extenuating circumstances. So the other problem or other portion of that comes in where we are sending off blood for research, where that,
Right.
in order to draw it and send it off, we absolutely do need to speak with the family and tell them exactly what that blood's being used for.
Yes, and I see Nicole's comment there, and I, for us, we have language that talks about research, and we absolutely support you all, OPOs making that call in tandem with their donor hospitals, knowing the family dynamic. So I think Nicole's clarification there and Phil's clarification, is if family has declined research and they're trying to reapproach based on hope, that they feel that there might be an opportunity there where they need to share with the family why this is a research protocol. But these are black swan events. I do see that the question from Robert. Robert, we are very excited to see, we're hoping that a cardiothoracic protocol will come online very soon. Many of our false positive donors would have been ideal for heart or liver or lung recovery as well. So there's a few transplant centers that I believe are interested in doing such a protocol, but for right now no one has a variance open. And part of that has to do with the amount of center experience with HIV positive transplants for other organs. And Dr. Stock can correct me if I'm wrong, but the majority of that experience at the transplant center level, that experience requirement is required under the federal safeguards and by the OPTN. There are very few centers who have done enough, which is 5 transplants for an HIV positive recipient to justify or to prove their expertise in order to get an open variance for cardiothoracic. Dr. Stock, is that correct?
That's correct. Yeah, we're going through that. We're going through that issue here because we've done. I think we're probably the only center that's done pancreas kidney transplants. We've done them in 7 patients for type 1 diabetes, and our results, surprisingly for that extensive of a procedure. It's pretty impressive how well those patients have done. But there have been some great donors, especially these false positives, that we have a very good idea are false positives, young, perfect donors. And many centers are interested in using those in HIV positive patients on their pancreas transplant waiting list. And these are centers that are we're the only center that's done the 5 required transplants. And personally, I think any center who has experience managing any organ transplants in people with HIV should be able to do it. And so we're I've been talking to UNOS about that. Because I think, but it is a problem, this experience requirement.
Dr. Stock, talking about experience in pancreas, can you share a little bit about your experience with pancreas and specifically islet transplant with HIV positive patients? Yeah.
Well, it's really interesting, Nikki. When we started to do this in 2001, when we really ramped up our programs and transplanting people with HIV, we had 2 or 3 type 1 diabetics who needed or people with diabetes who needed kidney transplants. And at that time, if you do a kidney pancreas transplant, you need induction therapy. You need thymoglobulin induction. And we weren't sure if patients would tolerate that because it completely wipes out your white count for almost close to up to a year. It turns out that patients do tolerate it, and we use thymoglobulin intermittently when patients are highly sensitized for kidney transplants, not liver transplants. I need to emphasize that. But we were nervous back in 2001, and so there were 2 patients that got living donor kidney transplants, were HIV positive, did well, but their diabetes was very problematic. And we went on to do islet transplants in them because we were very nervous about doing solid organ pancreas transplants because of all the complications, mostly infections that you can get. And so we did the islet transplants. And lo and behold, of those two patients, one of them remained insulin independent with a cellular islet transplant for 2 years after we did the pancreas transplant, and then he died of an MI. The other patient was only insulin independent for like 6 months and then became diabetic again. And as a result of that, we ended up moving forward with kidney pancreas transplants, and they've done well. Are you
and
still
why
there?
do you think that patients are having, yes, why do you think that patients are having higher rates of rejection if they have a immunocompromised immune system?
Oh boy, that is a
maybe
a really,
if you could
really hard
clarify.
question. I'll just tell you that there is cross-reactivity between the HLA antigens and the HIV virus. And many people think that you turn on an immune response against HLA antigen by having HIV and all the co-pathogens. So it looks like there's a lot of cross-reactivity with the immune response against infections and HLA. And that's what we're trying to dissect right now. And then the other problem, of course, and that's what I will leave you with, is that drug dosing is a problem. They are primed to reject, I will tell you that, and that's an immunologic phenomenon. But the other problem is we've got to do a better job of covering them with the right immunosuppression, and in order to do that, get them off the protease inhibitors, and that is the last thing I'm going to say. But thanks for the question.
Thank you. And if anybody else has any questions, please don't forget to submit them in the box on the screen. I think we've answered most people's questions. We answered Robert's question. No other questions so far.
Thank you, Nikki. If there are no additional questions, I'd just like to extend a sincere thanks to Dr. Stock and Phil, as well as Brianna, for sharing your expertise on such an interesting topic. Again, to everyone, I do apologize for the technical difficulties. I'd just like to thank everyone for joining us here today, and we wish you a wonderful rest of your week.